Sure, there are others still joining. So welcome everybody to this interRAI Australia hosted talk by Vince Moore. Before I start, I'd like to acknowledge the traditional owners of the lands on which we work and live, and pay our respects to elders past, present, and emerging. Now, this morning, we're really privileged to have Vince Moore with us from Rhode Island in New York. It's the land of the free, unlike Victoria and New South Wales, which are completely locked down, but half his luck. I don't know what you've done right over there, Vince, that we haven't done, but here we are. So Vince will say something about that, I'm sure. Every jurisdiction has its story. So Vince and I have known each other for a long time through our mutual fellowship within the interRAI Collaborative, and he's been kind enough to visit Australia on 2 or 3 occasions over the 20 years or so that we've known each other, and he's also been quite involved in interRAI developments in New Zealand. Importantly, he's had a tremendous research involvement in and policy involvement in what I would say is data standardization within long-term care in the United States, and he's been tremendously influential, I think, in using his research to influence public policy. And so he's a person we should listen to very carefully. I've always valued his knowledge and wisdom in the work that we do. So Vince is going to talk today about various aspects of the use of, I think, standardised data in long-term care, and in particular, he's going to refer to how such data has been used in the COVID pandemic and the COVID pandemic era. So thanks so much, Vince, and I'll hand over to you, and we'll no doubt enjoy your talk.
So it's my pleasure. Thank you very much, Len. Delightful. I'm going to share my screen now, if I may. Okay, we're in presenter mode, and I think I can control things now. So thank you very much. Good morning, everyone. It's the evening for me here in southeastern Massachusetts. I was at the beach a little while ago. It was lovely. So I'm happy to be presenting to you about work I've been involved with since the beginning of the COVID epidemic here in the US, because it's building on something that I'll describe, this National Institute on Aging IMPACT Collaboratory, which is designed to transform dementia care. So there we go. So the talk title is Building a Data Infrastructure to Monitor Public Health Emergencies, Treatment Innovations, and Policy Initiatives in Long-Term Care. And since I'm a researcher, and in the US, we have lots of different research funding that provides support for our research activities. There are 2 large grants. One is this IMPACT Collaboratory, which I'll describe in a little bit. And another is a large program project grant that I have also from the National Institute on Aging, looking at Alzheimer's disease and related disorders, looking at changing policies and systems in the US in the long-term care sector. Lots and lots of collaborators, too many to mention in this. But one of the things I do want to mention is this group, Genesis Healthcare. Richard Pfeiffer is the Chief Medical Officer. That's one of the nursing home companies that we've been working with. And it's been just a wonderful, wonderful mutual relationship since the beginning of the COVID intervention, as I try to put my research resources and smart young people at his disposal to try to help solve problems for them in the operating world as they were struggling to cope with the impact of COVID on a regular basis. So that's been a really wonderful relationship. So what I'd like to do today is to have briefly describe this National Institute on Aging, Alzheimer's disease and related disorders IMPACT Collaboratory, which is essentially a large infrastructure grant designed to support basically pragmatic randomized clinical trials in various settings that serve people with dementia in the healthcare system in the US. Then I want to summarize the original IMPACT data infrastructure that was the designed, and then what happened when COVID changed everything, and then how we actually put together a data sharing cooperative, and then are now extending that data cooperative for a broader sort of post-COVID aging research environment, stimulated by the availability of COVID as a stimulus for this. So let me talk to you about this IMPACT Collaboratory. So the leadership is myself and a woman named Susan Mitchell. Some of you may know her work. We've collaborated together for about 15, 20 years. She's a clinician, geriatrician, who has done a lot of work in end-of-life care. She's a scientist at Hebrew Senior Life, where John Morris, who's also an interRAI fellow, is located. This is a very large grant. So we actually have two executive directors, one at Hebrew Senior Life and one, Jill Harrison, at Brown University. And it's a very a large effort. I'll tell you about in just a second now. So the National Institute on Aging funds this activity. It was initially a $54 million 5-year grant, and now it's up to about 70 million with all of the supplements focused on COVID. We have a steering committee, which is made up of mostly members of our core groups and teams, plus a couple of outside people who are specialists in dementia by and large. And we have an external advisory panel of senior people who advise us, as well as the National Institute on Aging, on whether we're achieving our strategic goals, and advising us on what new initiatives we might try, or what initiatives are not working, et cetera. So there's an administrative and management core. And so we have grants administration, because we fund grants, large grants, small grants, career development awards, et cetera. So we have something like 40 or 50 people we've awarded grants to over the last 2.5 years. And that part and that process is underway. We also deal with organizational logistics, data flow, monitoring, et cetera. Then we also have data standards and sharing, which is basically a structure that we require all of our pilots and demonstration projects to use some common data elements, not a lot, but some. We also help with our pilots, so it help them navigate the complex system, because every year we fund a bunch of new pilots and they have to move through very quickly. So we actually do a lot of work to help them move along. We have then communication and knowledge dissemination. And then we, like all research, there's institutional review boards, data use agreements, et cetera, all of the regulatory apparatus that was required to do research. So we provide the infrastructure to make that possible for all of our pilots. Then we have a series of working groups and teams. So we have a pilot study core that advises people on how to construct outcome measures, an ethics and regulatory core, sort of, what kinds of institutional review board review does that have to be? One focused on health equity, another focused on, of course, design and statistics. We also have a major mission to train new people in this whole new area of research about pragmatic trials. And then, because doing trials of an intervention means that you have to implement that intervention, we have a major emphasis on how to implement, what the implementation is all about, et cetera. And then, of course, since we work with healthcare systems, we have a core focused on healthcare systems that is put together basically 4 learning communities to help new investigators match their research ideas with healthcare systems that are interested in hosting those kinds of structures. And because this is all engaging and working with people with dementia, their care partners, as well as the clinicians and healthcare systems that service them, we need to have stakeholder engagements who can tell us what's important from their perspective regarding the movement forward with dementia. I left to the last this technical and data core, and I'll talk about that right now. In just a moment. So there are more than 60 investigators from 30 institutions across the country that make up these cores, with all places from all over the U.S. Our mission is to build the nation's capacity to conduct embedded, pragmatic clinical trials of interventions that can be implemented in healthcare systems that are designed to assist and to make the lives of people living with dementia and their care partners better. So the goal here is to transform the quality of care that people receive, the outcomes of care that is provided to persons living with dementia and their care partners. And the goal is to do that by accelerating and testing the adoption of evidence-based interventions in healthcare systems. So to achieve our mission, we support the design and conduct of what are called embedded pragmatic clinical trials. We want to fund and guide these pilot trials as well as larger demonstration projects. So a pilot trial has to be done in at least 2 different settings, could be 4 or 6 different settings as well. It doesn't have to be a random assignment trial, although sometimes that's necessary in order to test all of the features because it's a pilot. That's up to $165,000 in direct costs. And then the demonstration projects have to actually be set up to be able to be powered for a full-scale trial. And these are up to $500,000 over a couple-year period. The resources are also for NIA. We also provide support and advice to other NIA-funded investigators that we don't fund, but that are doing pilot trials in this area. As I mentioned, we also build investigator capacity. So we offer career development awards, adjunct faculty, workshops, and online training modules. For those of you who are interested, you can go to impactcollaboratory.org and you'll get right to our website. There are lots and lots of training materials there, and I urge you to take a look at that. We also have this whole notion of developing an infrastructure to facilitate outcome measurement based on clinical trial, based on electronic medical records. And I'll be talking a lot about that. And so they also catalyze stakeholder engagement. And we also want to make sure that all of our research projects are culturally tailored, have culturally tailored interventions that can actually serve and help people from diverse and underrepresented backgrounds. So when we first designed the project, the idea was to have a technical data core that would offer real-time access to claims-based outcomes and to have those set up in such a way that it's possible to actually embed these trials within and to use electronic medical record systems. The infrastructure included what had been direct access to Medicare claims through what's called the Virtual Research Data Center. So we can actually, I have 3 or 4 staff people who are programmers. They sit online and they work directly on the Medicare computer in a location that's available. We also work with the people that created the mini-sentinel, which is an FDA-funded distributed research network of large healthcare systems, that those data, the data stay in the healthcare system, but there's a distributed research network. So someone writes code, gets companies to participate in that, and the code is then replicated in each setting and then brought back for consolidation. We had planned to do as well, when we first designed this, to have an EMR for healthcare systems participating in the IMPACT Collaboratory as well, and also from nursing homes, home health, and assisted living. And so what I'll be talking to you about mostly today is now the nursing home setting. So like everyone else, COVID changed everything. We'd already begun funding pilots, but of course the pilots, which hadn't been set up to be remote, were delayed by months and months and months, because as you may recall, the spring of 2020 was quite disastrous in the US, particularly the East Coast. Then new COVID supplements were funded and submitted. And so that made lots of things possible to do analysis very quickly, building together a data structure. And so there was a pressing need for real-time data, and that was able, and they were able to do that to examine the COVID effects. And then we started with data that was rapidly obtained from one company, that's this company Genesis, with nightly downloads of their complete electronic medical record information. And then we uploaded it from that download into analysis files that our analysts were able to work on in order to address research and practical questions that the nursing home investigators, the nursing home leadership needed answered. So then the next step was sort of last summer of 2020, we reached out to 12 other large nursing home companies, about 1,000 facilities, who all use the same electronic medical record that the group at Genesis, the healthcare system, a nursing home company that worked with. So we signed data use agreements with them, and they basically agreed to share all data, orders, notes, everything. And that includes a complete dump of the electronic medical record system for each company. And these are now updated monthly. The initial focus has been, for the last year or so since we've been doing these analyses, focused on SARS-CoV-2 testing through a special supplement that we got looking at testing for COVID-2. Then we also looked at, have seen this as the basis for pragmatic trials, and I'll describe that research in just a moment. Here's a view. This is about 1,000 nursing homes across the country. That is about 7 or 8% of all the nursing homes in the country. They represent virtually all states, all areas. And so it's a pretty good cross-section of all nursing homes in the country. They all have a common data infrastructure. The nursing home electronic medical records were built around the first electronic component of that, which was the mandatory minimum data set, which was sort of the derivative of, or an outgrowth of, interRAI. There are mandated annual and quarterly assessments, and in addition, change of condition updates, which are basically structured, as well as narrative on an ongoing basis. So as a person begin to have a spike of fever, there should be a structured assessment for identifying what the nature of the problem was. There's also something called the medication administration. It's all electronic. So imagine what's going on in Australia now. You have medication administration records that are virtually almost always paper, and the nurses have these at their disposal when they're actually doing med passing. And so they hand this out and fill it out. It's now all electronic in the US. And so those records basically tell us who got what drug when and for what purpose. The clinician orders are there. They're structured as well as narrative. We have quantitative lab testing results for many different kinds of labs for about half of the participating nursing homes. There are nursing notes, both structured and narrative. And then there are lots of different kinds of vaccination records for influenza, but also obviously for COVID vaccines. And then the diagnoses are there far beyond the interRAI checkbox. It's the full ICD code along with the date that the diagnosis was first made. So I'm going to now describe some examples of how we've used these data to address COVID-specific questions. But first, what we've done is, as I said, this data are downloaded every month. Within 15 days of their being downloaded, we generate a report that goes to each one of these 12 companies. And this is just some slides focused on COVID. For instance, here's among residents with COVID-19, what percentage were post-acute, that is, were just there for a short stay versus long stay. And so the post-acute is a relatively small number in this particular company, and most of them are for long stay. Here on the right is the sort of cumulative ranking or cumulative gearing of all of COVID-19 diagnoses. And here's what it looks like as a mixture of new COVID cases in the building versus long stay cases who had already been there. And this is just other material on the side, but there are other descriptors that for other pages we have. So this is one of the first COVID vaccine related studies that we did. We did lots and lots of studies on testing. I had to limit how much I could present to you here. So here we see the blue lines are the case rates of early vaccinated nursing homes. That is, these are nursing homes and residents that were vaccinated between December 18th and January 21st. And then the late vaccinated ones were vaccinated between January 21st and then February 21st. And so what we do is we compare the case rate of early vaccinated nursing homes relative to the case rate of late vaccinated nursing homes. And as you can see here, there's the early vaccinated homes had slightly higher rates of COVID in the weeks before the first vaccination. That quickly settled back, and then they dropped below the line as you moved all the way through for the first 14 days after the vaccination to the second 14 days after the vaccination. And the red line looks at the actual mortality and or hospitalization rates, where we see the same kind of thing going on. And when we do some fancy statistical modeling on this, we find that lower infection rates than would have been predicted, which resulted in a cumulative reduction of about 5.2 cases per 100 at-risk residents when we compare the vaccination rates and the outcome rates of people who were in the first wave of in the buildings that were vaccinated first relative to the buildings that were vaccinated second, on the assumption that it was not the patients, but the buildings that were sorted. And so when we look at this in terms of the mortality, the early nursing homes had a predicted 1.1 to 3.8 fewer hospitalizations or deaths per 100 infected residents per day, averaged by week, which actually came to a cumulative difference of about 5 events per 100 infected residents per day. So that's a pretty big number of basically saved lives. It's a paper, we put it in the New England Journal, which is looking at the incidence of new asymptomatic and symptomatic SARS-CoV-2 infections following residents who were vaccinated with their first dose and then residents vaccinated with their second dose. And here you can see after their second dose, at 14 days after their second dose, there are only 0.3% of the people who were vaccinated, who had 38 out of this 13,000 had an infection. And of those, 76% were asymptomatic. That is, they were infected and tested positive, because there's a lot of testing that goes on in nursing homes of both staff and residents. But by and large, when the testing occurred, they were not even symptomatic, much less anything else. So it's a really big success story. Then we watched this a little bit longer, and we said that, over time, as you know, there's all this big discussion in the US now about should we do boosters or should we not do boosters? And we're in the process now of doing boosters in the US of people who are immune compromised, taking immune suppressant drugs, as well as people who have organ transplants or otherwise, because you see that there is this rise in infection rates, but most of them are still asymptomatic, even though there's a rise at about 6 months after the first days of vaccination. We also had a contract from the Centers for Disease Control to look at adverse events post vaccination. This vaccine came out so quickly with really great clinical trials results, but the people who were going to be the first persons to get this vaccine after the healthcare workers were people in nursing homes. And so the people at CDC were deathly worried that there were virtually no people in the clinical trials who were this sick or this old, the nursing homes. And so we were deathly worried that there would be actually a very big problem of adverse events in this much frailer, sicker population. And out of 13,000 people, this is the number of adverse events. And so the deaths, when we looked at that, actually, there was no difference whatsoever in the early vaccinated versus the late vaccinated in the deaths. And we also looked at that in the vaccinated versus unvaccinated. And the overall mortality rate was no greater this year than it was in the year amongst the vaccinated in the years past. So it made a big effect. And this actually had a huge influence on these data, had a huge influence on CDC's special committee to look at vaccine effectiveness. But we didn't just stop there. We also tried to do a trial. We did a trial to improve vaccine uptake in nursing facilities, as well amongst patients and staff. So this was an example of the advantage of having a cadre of nursing homes already contributing data, already willing to participate in research. So of the 12 companies, 4 volunteered at the drop of a hat to be part of a rapid randomized trial, et cetera. So we received our initial funding from the National Institute on Aging on October 4th. Then the pharmacy partnership, that was announced that there would be a rollout of vaccines that would be done by big pharmacy companies, not pharmaceutical companies, but by pharmacy companies, and that was announced in mid-October. And then the first vaccinations occurred with Pfizer. The first vaccinations occurred on basically December 18th. So the Pfizer was given emergency authorization on December 13th, and Moderna a few days later than that. And then all this period here, during this time, between when the pharmacy partnership began and we had our trial begin, was we were trying to talk the National Institutes of Health into allowing us to do this vaccine trial, to pivot from working on testing to working on vaccination. So that they gave us approval just at the same time the Pfizer was approved. We got IRB approval literally 6 or 7 days later. Then literally 5 days after that, we had approval from our Data Safety Monitoring Board. And then we began literally the next day, our first town hall meeting with people in the nursing homes, and then kept them up every single night and began shipping incentives and other kinds of things to get to the intervention. So this was a trial like none I've ever been involved with. We were working basically day and night to get all of this up and moving as we move through the process. Intervention was basically starting with electronic messaging and education to patients and staff. We identified opinion leaders from within the nursing home staff to actually influence. We already knew very early on that the staff were going to be the challenge and not as much the patients. We then reached out to engage community leaders who were identified by the opinion leaders who were staff members in order to reinforce the measure of get your vaccination. We sent out lots of what we call as swag, vaxxed for you, all kinds of little mementos, t-shirts, things like that, masks, etc. And then we also made available a consenting specialist to help family members and patients overcome the barrier of becoming vaccinated and getting consent if they needed it for patients or family members signing up. And then we also provided funding to the nursing homes because many of the initial adverse reactions or responses that people have to the vaccine are also the same kinds of responses that people have to COVID in terms of those same kinds of symptoms. So that we had extra money to do testing so that people, if they had symptoms, they could get tested to make sure that they weren't actually also having COVID. The randomized trial was set up to with a drawing from 4 different companies. We identified 133 facilities eligible for random assignment. Using the data we already had, we were able to stratify the nursing homes based on the proportion of minority population, and then randomly assign with an experimental control as well within that. We also stratified by which chain they were part of, because there were 4 different nursing home companies. Very briefly, these are the population descriptions. This is all like information that would be on an interRAI record. We know what the length of stay of those people are, their gender, their race, and their some specific comorbidities, and whether they'd had the influenza vaccine in the fall of 2020. And as you can see for the patients, it was pretty high. And then this is just some characteristics of the overall facilities that were in the group, and the number of staff per facility. The average number of staff was about 130 staff in those buildings. Unfortunately, partly because it was rushed, partly for other reasons, the intervention that we implemented didn't increase vaccine uptake amongst either patients or staff. There were really no differences in the effect estimate. It was like 0.8% and 1.1%, but it was not statistically significant. And the rationale was it really does take time to improve trust, to establish frontline champions. There are still nursing homes in the country where a reasonably high proportion of staff are not vaccinated, and many companies are now grappling with the very difficult decision of whether to mandate and have their staff, some of whom have been with them for a long time, leave them because they're not vaccinated. So there are various strategies people are trying to work on. But there's also organizational culture, there's trust in leadership and trust in fellow staff. Stability of that staff is key for actually getting things done in these nursing homes and keeping patients safe and secure. So this is not over by any means. There's a new booster shot vaccine becoming available this fall, and we're going to be studying it. I don't know if we're going to be able to do another trial, but what's one thought is we've thought about that as well. So that's the extent to which you can do that. So one of the things that we've thought about and are now in the process of doing is building a data infrastructure that we can actually use for the future. So we want to expand the current data sharing cooperative to include up to 10,000 different nursing homes. We're going to include nursing homes with 4 different electronic medical record systems. All of this has frequent updates of ADL, medication administrations, et cetera. And then ultimately, these data will be linked to Medicare claims. These are all Medicare, basically these are insurance claims, as well as Medicare Advantage records, which is a different kind of Medicare insurance. And this creates an opportunity it creates a database for monitoring changes in patients' condition, changes in the industry altogether. It monitors, allows us to monitor the diffusion of new medications. So we're now doing this with the 1,000 nursing homes to look at the diffusion of monoclonal antibodies as treatment for COVID and other purposes. It's also available as a pool of nursing homes with known data for participation in clinical trials or specialized data efforts. And then it also provides literally a picture of a next generation of linked data for clinical and policy analysis. Shortly after the minimum data set was created in the early 1990s in the United States, I was amongst the first people to take those data once they were computerized from 4 or 5 states in the US and then merge them with these Medicare claims and also with medication administration records. And that provided an insight into what was going on in US nursing homes that had never happened before. Now that we can do this with electronic medical records, you could do this more frequently, you could do this updating, you could do this in real time and get much cleaner data with much more detailed medication and also much more detailed narrative about patients' conditions. So this new structure that we've pulled together has up to 10,000 nursing homes. They instruct their EMR vendors to send the data to a large engineering company we work with. They're going to put this stuff on the Amazon cloud with all kinds of other integrated together. And then this coded data is going to go to another company that has contracts with both Medicare as well as from the National Institute on Aging. And those data will be then used for research analysis that's funded by the National Institute on Aging. And I'm going to skip this technical part because I'm taking a little too long and just talk to you a little bit about the future. So Brown and IMPACT, we will be the first users of these data. We're planning now for other National Institute on Aging investigators to request data use that we would review. And there will be 2 databases. One is the EMR and claims match data, which can be used for public health surveillance, for pharmacoepidemiological research, for testing the impact of new treatments through observational effort, as well as the impact of new policies, payment schemes, etc. But then the EMR data only are going to be at the service of the nursing home industry so that the engineering company is going to actually feed back in almost real time alerts that are patient specific based on artificial intelligence algorithms that are set up. We're going to be then ultimately repeat what we did with the COVID vaccine testing, is to recruit these facilities for cluster randomized trials. We want to also be able to recruit facilities for clinical research. There are now increasing patient monitoring devices that you could put on to monitor glucose, to monitor heart rate, to monitor cardiovascular condition, blood flow, etc. And this basically will make the teaching nursing home of the future. And so we anticipate maybe 40 or 50 or even 100 nursing homes will participate in this, with many of their residents, of course, would have to be consented, signed up for this kind of patient monitoring with funding by the National Heart, Lung, and Blood Institute, for the National Diabetes and Kidney Disease Disorder Group, because there are many, many research questions about what's the right dosage, what's the right treatment for people who are very frail and old in nursing homes. And to date, we just haven't got them. And then also ultimately doing recruiting for real world phase 3 trials that will require patient family consent, but that the EMR would both be used to identify potential subjects as well as to identify outcomes. So what's critical here is that contrast to many other kinds of distributed data networks, having these data in a centralized repository means that you have a common trusted data custodian, that there's a waiver of consent that this happens from in the US. As part of that process, the data can be used. The data access is controlled by data use agreements with each individual company, where the data are there, that they can opt in or opt out of various studies at their will. And then facilities offer, it facilitates the ability to have different views per research request, because once they're set up so that, you know, I could look at just facility level data, or I could look at only patient level data, but I don't know what building it's in. And all of these things are possible with different views when the data can be centralized and with a common trusted data custodian. So I'm going to stop there. We still have about 15 minutes for questions, and I'm happy to take any questions. And who's going to be, I'll stop sharing and we can open it up. Murray, you're going to do that?
Thanks, Vince. Yes, there are no questions in the Q&A or chat. So if anyone from the audience would like to ask a question, just raise your hand. I'll spot you and I'll unmute you so you can ask Vince your question. Okay, someone has a hand up. Len.
That would be me. just to get, that was fantastic, Vince. We're in the very early stages of trying to do something like that here at UQ, and so it's very exciting to see it at scale. I'm interested to hear how you fund this enterprise. To what extent, in this country, our long-term care facilities claim to be struggling financially, and I think it's true. So getting them to invest in what I think many of them would enjoy participating in would be very difficult in their financial context. So how have you been? What's the secret ingredient that gets this to happen?
So the EMRs that they currently have in place were designed primarily for billing, but they're also designed for quality oversight, quality review, and management. We believe that we are going to actually be giving them information and reports that they're currently not getting, that have value, and they will have input into what the structure of the report is. So right now I showed you a copy of one of the reports that we do, but we can actually embed that directly into the EMR as a report for them to see on a regular basis for things that are of value to them. It's always difficult not to flood people with too much information, but you have to just be aware of that. And I have finally learned that. So it took a long time to learn that lesson. In addition, they're also going to, because their EMR is real time, and we have the ability to reach into that because it's a two-way scene between our engineers and the EMR companies. We can actually send messages that are patient-specific alerts that can actually then be seen at the individual patient bedside or at the nurse's station in those in the nursing homes that are participating. So we think that provides some value. Now, this big infrastructure that we're putting together, the National Institute on Aging has funded that. This is like a $4 million grant to build this infrastructure, set it in place, and then in the future, it has to pay for itself by researchers being able to pay for the data that comes out of it, and some revenue sharing goes back, a little bit of revenue sharing goes back to the nursing homes. We also believe that that for the pharmaceutical companies, there will be considerable interest in some of this kind of information. It will be completely de-identified. They won't have access to who the companies are, or who the obviously who the individual patients are, but they're going to want to know who's taking which drugs of theirs and how much, and they're going to also want to know what is going on in the nursing home setting where so many drugs are offered. So we believe there's going to be a market for from industry for the drugs, for the data, for looking at the data. No one takes the data off those servers. The data stay under the custodian's care, and they can't be taken down and away, no matter who it is. So with the kickstart, we believe the infrastructure can be sustained. We hope it can be sustained by both researchers as well as industry. And there will be value to the nursing homes themselves. Now, only nursing homes with an EMR are part of this. Now, in terms of nursing homes participating in research with sensors or in clinical trials research, they have to have some kind of compensation from the researchers. So when no one does a clinical trial in a hospital without paying a lot of money for the infrastructure and so on and so forth, the same is going to has to be true for nursing homes.
Thanks, Vince. We have a question from Joanna. Would you like to ask your question, Joanna, and just briefly introduce yourself?
Hi, I'm Joanna Westbrook. I'm Professor of Health Informatics and Patient Safety at Macquarie University and work with Len on a number of aged care projects. And like Len, we're very envious of this enormous, fantastic infrastructure that you've established, and we are only just starting to do this in Australia. One of the questions I had was around about how do you build capacity among nursing home staff to be able to respond to this data? So it's all very well to show them they've got variation in practice, they need to do something, but the skills level, the sophistication in understanding data, even at a board level here is really quite low. So I was interested to see how you went about really trying to build that capacity.
So Joanna, that's the most important question ever. As I think I hinted at early, it's all about implementation. So I've now done 4 large-scale pragmatic clinical trials trying to alter the way in which care is delivered to subsets of populations in intervention nursing homes. And not one of them has defeated the null hypothesis, as it were. And a lot of it is due to complications of implementation. In the US, so for instance, in the US, we have fairly high turnover of nursing staff and of aides, obviously, and they're critical to actually managing the care of these frail residents. So we have to figure out some way to intervene, to train, and to sustain those people in the nursing home setting. And as Len said, nursing homes are worried about being able to keep their heads above water fiscally. And if we as a society want to keep asking these people to take care of the sickest of the sick, then we have to be prepared to pay them more and to professionalize them in a way that has occurred in hospitals over time. Now, mind you, even hospitals' quality improvement efforts take a long time and a lot of effort to implement. So this is, we can set up the engine, we can get it to go, but actually making a difference in the lives of the nursing home residents and in the lives of the people who take care of them so that they can respond and adhere to new ideas and be excited about new ideas, that's a lot of work.
Thank you.
Thanks, Vince and Joanna. Magda has a question.
Yeah, thank you. My name is Dr. Magda Raban. I'm also from Macquarie University and work with
Hello.
Hello.
Yes, hi. So Dr. Magda Raban here,
Yeah.
also from Macquarie University. Yeah, fantastic work and very exciting. I guess my question is about, you mentioned that these EHRs are not really designed. They're designed for billing purposes. And that's sort of similar to Australia, where a lot of these systems are designed around the purposes of billing, but also, day-to-day care delivery, and not necessarily for the purposes of providing useful reports to the facilities and providers more broadly. So I'm just wondering whether you see that the work that you are doing could potentially result in changes at the vendor's end in terms of how they design these systems and whether they are amenable to changing the systems so that they are better for reporting purposes, as well as providing more useful feedback at the ground level during delivery of care, like decision support.
Yeah, Yeah, so those are great questions, and both you and Johanna are informaticists, so you're far beyond me in terms of my understanding of this stuff. But just historically in the U.S., there were many nursing homes that had billing systems before there was a minimum data set. The minimum data set was imposed, and for a while, people had sort of freestanding minimum data set systems and then their billing system separately. And then the vendors said, we have to put this together because in fact, the billing would required in order to be billing with a case mix, required that those two, that the MDS data actually and the billing data could go together. So that idea of taking clinical, quote unquote, assessment data and linking it to billing for billing purposes was automatically done in the context of the nursing home setting. And then little by little, the nursing homes began to add modules. Mostly they added modules that had a billing component to it. So the first module that they would add would be drug ordering. But then from a regulatory perspective, they not only needed drug ordering, they needed to be able to document, because of audit and oversight, who was delivering which drug when. And so, because that's a quality oversight thing that the regulators come and audit and do when they do inspections on all the time to make sure that people aren't getting the wrong medication, aren't getting poorly dosed. So all of a sudden there's another motivation. And then the companies would then begin to put these systems together. And sometimes they're better designed, sometimes they're worse designed, but all of a sudden these different modules can be used to work together. Now, because the people who design these systems, they're data nerds, they're systems engineers, they know nothing about nursing home care, they know nothing about clinical care. It's our responsibility to work with them to come up with what are the reports that the people who are operating these places that are clinically useful to clinicians as they make a morning report, as they identify people who are at high risk. Those are the algorithms that we can then introduce, that the companies can then use the existing data to generate. And that gives the incentive for the nursing home to actually update the data on a more frequent basis. Because what you'd like is you'd ultimately like these data to be live and real, just like they are in a hospital. Because once they're live and real, then you can use them to identify patients who fit your requirements for a randomized trial. You could identify outcomes from the clinical data that are relevant to a particular intervention, not just are you hospitalized or did you die? And so this is, I view this as a long-term progressive process, that it does require if not the nursing home users, then the people who are the investigators working with the nursing home users to improve the quality of care, to work with the vendor. So in that sense, it's a three-way, it's a triangle, and all of those sources have to work together.
Thanks, Vince. Any other questions? Just pop up your hand. Magda, you can ask another one or respond to that if you like while I'm waiting. Or Len, leap in.
Yeah, also, Vince, obviously a sentinel event in all of this was the introduction of the MDS back in the 90s.
Yep.
And we don't have in Australia such an MDS, although we do have certain clinical data that feeds the payment arrangements, but it's it's not a comprehensive clinical profile. So how important is it that government mandates something as opposed to, let's say, provider organisations building something from the bottom up? There's this discussion, of course, it goes on endlessly in interRAI, but do we really need top down and bottom up pressure to create such a resource? What's your thought about that?
So my opinion is that it's never top down only, because if the bottom up, we're not somehow or another saying the future is going to require this, we're going to need this. If there's not some clinicians and or leaders in the industry who see this vision and think it makes sense, the top down will not work, because then they'll be very happy to live with a 20 item case mix index attached to billing data, and then the government just has to worry about upcoding all the time. They always have to worry about upcoding. They have to worry about upcoding in hospitals and doctors' offices. If you bill that way, you're going to upcode. There's no question about it. You could design some kind of checks and balances, but you don't want to make it so obvious that it's only upcoding with no alternative. And I think clinicians want to be able to know something about their patients and characterize their patients. The first time I saw the MDS really, really used well was when I went into a sort of the morning report, and they looked at the 10 patients. It was a post-acute setting. They had 10 to 15 admissions a day. Every morning, the clinical team would meet and say, tell me about Mrs. Jones. And they would use language from the MDS to characterize that acuity in addition to the diagnostic and drugs. And it was clinically useful to them.
I think we're close to time. That was, gee, Vince, I've heard you many times. That was even exceeded my expectations to hear that talk. So you've come a long way, and it's really inspiring to see what can be done. And I'm particularly excited about the providers having massive buy-in to this idea. Yeah. And that's not as opposed to government, but complementary to government's aspirations. Yep. We know our government wants providers to take the initiative and to drive improvement. And so it does need to be top down, bottom up, of course. But the way you've that structure you've described is really inspiring, and something we might get back to you and talk to you more about this sometime in the future.
Happy to do so.
We can't clap, unfortunately, but I know everyone feels that was a fabulous talk, and we'll no doubt be in touch on many fronts in the future. Talk soon.
I hope I could come visit you again one of these days if the world becomes sensible again.
I've been planning your visit for some years, and it's getting thwarted all the time. Anyway, it'll happen.
It'll happen. Take care. Thank you all very much. Bye-bye.